Welcome back to AudioBoards. Today we're covering one of the most important diseases in pulmonary medicine and inpatient care, chronic obstructive pulmonary disease, or COPD. COPD is a disease every clinician encounters, whether in primary care, hospital medicine, emergency medicine, critical care, respiratory therapy, or pulmonary practice. Yet, despite how common it is, COPD remains significantly underdiagnosed and undertreated. In this episode, we'll cover what COPD actually is, risk factors, diagnosis, classification, treatment, exacerbation management, oxygen therapy, pulmonary rehabilitation, and the major comorbidities you need to know.
So basically, if someone listens to this episode, they should walk away with a solid framework for understanding COPD from diagnosis through management.
Exactly, that's the goal.
What is COPD?
Let's start with the definition. COPD is a chronic, heterogeneous lung disease characterized by persistent respiratory symptoms and airflow obstruction caused by abnormalities of the airways, alveoli, or both. When we say airway abnormalities, we're talking about chronic bronchitis and small airway disease. When we say alveolar abnormalities, we're talking about emphysema. The key feature is airflow limitation that is not fully reversible and is usually progressive over time. Patients commonly present with dyspnea, chronic cough, sputum production, wheezing, recurrent respiratory infections, exacerbations. The hallmark symptom is progressive shortness of breath. Many patients initially notice difficulty climbing stairs, walking uphill, or keeping up with peers.
Why does COPD happen?
Historically, we thought smoking caused COPD, and that was essentially the whole story. Now we know it's much more complicated. COPD results from a combination of genetic susceptibility, environmental exposures, and lifelong factors affecting lung development and aging. The most important risk factor remains cigarette smoking, but smoking is not the only cause. Other causes include secondhand smoke exposure, biomass fuel exposure, indoor air pollution, occupational dust exposure, chemical fumes, outdoor pollution, alpha-1 antitrypsin deficiency, poor lung growth during childhood, recurrent childhood respiratory infections. One of the major updates in recent years is recognition that COPD can begin much earlier in life than previously thought. Some patients never achieve normal peak lung function and therefore develop COPD, despite never being heavy smokers. So smoking is still the biggest risk factor, but not every COPD patient is a smoker? Exactly. That's an important board-style concept. Let's talk about what's actually happening in the lungs. COPD causes chronic inflammation. Over time, this inflammation leads to airway narrowing. The bronchi become inflamed and remodeled. Excess mucus production. Patients develop chronic productive cough, loss of elastic recoil, particularly in emphysema. Air trapping. Air gets into the lungs but has difficulty getting out. Hyperinflation. The lungs become chronically overexpanded. As hyperinflation worsens, the diaphragm flattens and becomes less efficient. Patients end up using tremendous energy just to breathe. This is why severe COPD patients often look exhausted after minimal activity. Traditionally, COPD has two major phenotypes. Chronic bronchitis, defined clinically as productive cough for at least 3 months per year for 2 consecutive years. The dominant problem is mucus hypersecretion and airway inflammation. Emphysema, defined anatomically as destruction of alveolar walls. This causes loss of surface area, air trapping, hyperinflation, reduced gas exchange. Many patients actually have features of both.
So, how is COPD diagnosed?
This is critical. Symptoms alone do not diagnose COPD. Spirometry is required whenever you see chronic cough, dyspnea, sputum production, smoking history, occupational exposure. You should think about COPD and obtain pulmonary function testing. The diagnostic criterion is post-bronchodilator FEV 1 to FVC ratio less than 0.70. No spirometry, no definitive diagnosis. Why post-bronchodilator? Because we want to determine whether obstruction persists after bronchodilation. If obstruction completely normalizes, you're likely dealing with asthma rather than COPD.
How do we use gold grading of airflow obstruction?
After diagnosis, severity is graded using FEV 1% predicted. Gold 1 is mild, with FEV 1 greater than or equal to 80%. Gold 2 is moderate, with FEV 150 to 79%. Gold 3 is severe, with FEV 130 to 49%. Gold 4 is very severe, with FEV 1 less than 30%. But remember, treatment decisions are no longer based solely on FEV1. Symptoms and exacerbation history matter tremendously.
How do we assess symptoms?
Two commonly used tools are MMRC dyspnea scale, measures breathlessness, CAT score, COPD assessment test, measures symptom burden and quality of life impact. These help determine how much COPD affects daily function.
What is gold ABE classification?
Modern GOLD guidelines classify patients into Group A with low symptoms and low exacerbation risk, Group B with more symptoms and few exacerbations, Group E with frequent or severe exacerbations. This system helps guide initial therapy.
What are the treatment goals?
There are two major treatment goals. First is to reduce symptoms. Second is to reduce future risk. That means preventing exacerbations, hospitalizations, lung function decline, death. Everything we do falls into one of those categories.
How important is smoking cessation?
If there's one intervention that changes the trajectory of COPD, it's smoking cessation. Nothing comes close. Smoking cessation slows lung function decline, improves symptoms, reduces mortality, reduces exacerbations. Use every available tool. Counseling, nicotine replacement, varenicline, bupropion. This is one of the highest yield interventions in medicine.
What about the vaccinations?
Vaccination is another major component of COPD care. Patients should receive recommended influenza vaccination, pneumococcal vaccination, COVID vaccination, RSV vaccination when appropriate, TDAP if needed, shingles vaccination. Respiratory infections are a major trigger of COPD exacerbations. Preventing infection prevents hospitalization.
What about pharmacologic management?
Bronchodilators are the foundation of pharmacologic treatment. There are two major long-acting classes. LABAs, long-acting beta agonists. Examples: salmeterol, formoterol, olodaterol. LAMAs, long-acting muscarinic antagonists. Examples: tiotropium, umeclidinium. Both improve dyspnea, exercise tolerance, quality of life. Many patients eventually require dual therapy with both LABA and LAMA.
When do we use inhaled corticosteroids?
This is commonly tested. Inhaled corticosteroids are not first-line treatment for everyone with COPD. They're most useful in patients who have frequent exacerbations, have elevated eosinophils, have features overlapping with asthma. Remember, ICS therapy increases pneumonia risk, so we use it selectively. So COPD doesn't automatically equal inhaled steroids? Correct. That's an important misconception to avoid.
And what is pulmonary rehabilitation?
It is one of the most underutilized therapies in COPD is pulmonary rehabilitation. Pulmonary rehab combines exercise training, education, breathing strategies, self-management training. Benefits include improved exercise tolerance, less dyspnea, better quality of life, fewer hospitalizations. Virtually every symptomatic COPD patient should be considered for pulmonary rehabilitation.
When do we consider oxygen therapy?
Many people assume oxygen helps every COPD patient. That's not true. Long-term oxygen therapy improves survival, primarily in patients with severe chronic resting hypoxemia. Think PaO2 less than or equal to 55 millimeters of mercury, or SaO 2 less than or equal to 88%. For patients with only moderate desaturation, routine oxygen therapy has not demonstrated the same survival benefit.
How do we manage COPD exacerbations?
Now let's move into one of the highest yield sections, exacerbations. A COPD exacerbation is an acute worsening of respiratory symptoms beyond normal day-to-day variation. Typical findings include increased dyspnea, increased sputum volume, increased sputum purulence, wheezing, chest tightness. Common triggers include viral infections, bacterial infections, air pollution, other inflammatory insults. However, not every patient with worsening dyspnea has a COPD exacerbation. Always consider mimics.
What are the exacerbation mimics?
Important mimics include pneumonia, pulmonary embolism, heart failure, pneumothorax, acute coronary syndrome. Failure to recognize these can be dangerous.
And how do we manage acute exacerbation?
Management begins immediately. Bronchodilators, short-acting beta agonists are first line. Usually albuterol, often combined with ipratropium. Corticosteroids, prednisone 40 mg daily for 5 days is commonly used. Benefits include faster recovery, improved lung function, reduced treatment failure. Antibiotics, we use it when there is purulent sputum, increased sputum volume, increased dyspnea, concern for bacterial infection. The typical duration is 5 days.
When do we use oxygen in exacerbations?
That is the board favorite. Avoid excessive oxygen administration. Target oxygen saturation 88 to 92%. Why? Because excessive oxygen can worsen hypercapnia in susceptible COPD patients.
When do we use non-invasive ventilation?
If a patient develops acute hypercapnic respiratory failure, non-invasive ventilation is one of the most effective therapies we have. Think BiPAP. Benefits include reduced work of breathing, improved gas exchange, lower intubation rates, reduced mortality. This is a cornerstone therapy for severe exacerbations. And when BiPAP fails, then we consider intubation? Exactly. Another important factor to consider is COPD rarely exists alone. Major comorbidities include cardiovascular disease comprising hypertension, coronary artery disease, heart failure, and atrial fibrillation. Lung cancer, one of the leading causes of death in COPD patients. Anxiety and depression, which is frequently overlooked. Osteoporosis, sarcopenia, GERD, and obstructive sleep apnea. Especially important in obese patients. These conditions significantly affect outcomes and should be actively screened for.
What does follow-up mean for these patients?
Every COPD visit should assess symptoms, dyspnea, exacerbation frequency, medication adherence, inhaler technique, smoking status, vaccination status, exercise participation, oxygen needs, and comorbidities. Remember, many treatment failures are actually inhaler technique failures. Never assume patients are using inhalers correctly. Watch them demonstrate it. Let's finish with the key points every learner should remember. COPD is a common, preventable, and treatable disease characterized by persistent airflow obstruction. Diagnosis requires spirometry, with a post-bronchodilator FEV1 to FVC ratio less than 0.70. Smoking cessation is the single most effective intervention to slow disease progression. Long-acting bronchodilators are the foundation of maintenance therapy. Pulmonary rehabilitation improves symptoms, exercise tolerance, and quality of life. Exacerbations should be treated early with bronchodilators, corticosteroids, and antibiotics when indicated. For acute hypercapnic respiratory failure, non-invasive ventilation saves lives. And finally, successful COPD management requires addressing the whole patient, including cardiovascular disease, mental health, nutrition, sleep disorders, and other comorbidities.
That's a great framework. COPD is much more than just an obstructive lung disease. It's a chronic systemic disease that requires long term comprehensive management.
Exactly. And that's where we'll end today's episode. Thanks for listening to AudioBoards. Stay tuned for more educational content in our next episode. The views and opinions expressed on the AudioBoards podcast do not necessarily reflect those of our employers. This podcast is for educational purposes only and should not be used to diagnose or treat any medical conditions. It is not a substitute for professional medical advice. Always consult a qualified board-certified healthcare provider for any medical concern.